Very good morning to all. In my last lecture, I have been discussing about the local anesthetics. In this lecture, I will be discussing about the general anesthetics. As you know that how the local anesthetics differ from general anesthetics. Local anesthetics produces a reversible loss of sensation, whereas general anesthetics produces a reversible loss of consciousness. You should underline the word reversible. Local anesthetics reversible loss of sensation, whereas general anesthetics produces reversible loss of consciousness. So these general anesthetics usually depresses the central nervous system. ಎಲ್ಲ modalities of central nervous system ಎಲ್ಲ modalities will be depressed by the general anesthetics. If you see the features of general anesthetics, there will be loss of sensation, especially the pain during the surgery, and they produces sleep, unconsciousness as well as loss of memory, and there will be immobility and complete relaxation of the muscles, and also there will be abolition of the somatic and autonomic reflexes. If you see what is the cellular mechanisms involved in anesthesia, there will be two important physiological effects at the cellular level by the general anesthetic. The first one is hyperpolarization of the neurons. You know what is meant by depolarization and action potential, which is essential for the conduction of the impulses. So at suboptimum level, below the anesthetizing level, there will be hyperpolarization of the neurons. And in our body, there are two kind of synapses. One is excitatory, another one is inhibitory. So the inhalation anesthetics, that is either volatile gas or liquids, can inhibit the excitatory synapse and enhance the inhibitory synapse. Second physiological effect is anesthetizing the concentration. Both inhalation as well as intravenous anesthetics have substantial effect on the synaptic transmission and much smaller effects on action potential generation and propagation. And if you see the molecular action of anesthetics, there is one inhibitory neurotransmitter in our body that is called GABA, gamma aminobutyric acid. So usually the general anesthetics increases the sensitivity of the GABA A receptor to the neurotransmitter GABA. Thereby, there will be enhancement of the inhibitory neurotransmitters effect and depression of the central nervous system. And if you see the stages of anesthesia, there are four different stages of general anesthesia. First is called the stage of analgesia. The second is called the stage of excitement or delirium. And the third one is called the stage of surgical anesthesia. The fourth one is called the stage of respiratory paralysis or medullary paralysis. The role of anesthesiologist during surgery is to maintain the patient at the third stage itself. Otherwise, the operation is success and the patient's died will be the result. So, the role of anesthesiologist is to maintain the anesthetic concentration at the third stage itself. If the patient goes to the fourth stage, that is called respiratory paralysis, thereby there may be chances of the death. Here I would like to explain various stages of anesthesia. The stage of analgesia, where there will be loss of pain sensations. So the patient progresses from conscious and conversational to drowsy amnesia and reduced awareness of pain. The second stage is called the stage of excitement, or as it is called delirium. In this stage, there will be irregularity in the blood pressure and also the respiration, and there may be chances of the laryngeal spasm in the second stage. The third stage is again divided into four sub stages. The plan one is there will be revolving of eyeballs. At the end of this substage, eyeballs become fixed, and in substage 2, there will be loss of corneal and laryngeal reflexes. On stage 3, plan 3, there will be a dilation of the pupil and absence of the light reflex. The plan 4 is intercostal muscle paralysis and the dilated pupil. The fourth stage is called respiratory failure or medullary paralysis. The overdose of anesthesia leads to medullary paralysis and also the vasomotor collapse. Now, the general anesthetics can be classified into three categories. So, the one is called inhalational, the second one is called intravenous, and the third one is called dissociative anesthesia. So, inhalational gases as such can be given, or the liquids can be converted into gaseous form. Under gas, you know the laughing gas, otherwise called nitrous oxide. In liquids, ether, halothane, enfluorine, isofluorine, desfluorine, and sevofluorine. And some of the general anesthetics can be given by intravenous route. The best example is ultra-short acting barbiturates, thiopental sodium, propofol, methoxytane sodium, etomidate, and some of the benzodiazepines like diazepam, chlorazepam, midazolam. So this is slow acting and less potent intravenous anesthesia. And dissociative anesthesia example is ketamine, and there are some opioids that also produces anesthetics. Example fentanyl. Now, if the properties of an ideal anesthetic, if we see at a triad, the triangle, it should be it should satisfy the patient, surgeon, as well as the anesthetist. Percent non-irritating, and it should not produce nausea and vomiting to a patient. For the surgeon point of view, we should produce analgesic, satisfactory analgesic activity. The patient should be in immobile conditions, and we should produce satisfactory muscle relaxation. Suppose if it is not producing the satisfactory muscle relaxation, then initially the patient has to administer with succinylcholine, like a skeletal muscle relaxant, and the drug should be non-inflammable and non-explosive. For the anesthetist point of view, the administration should be easy, controllable, and versatile. The main thing is margin of safety should be wide, and it should not produce any hypertension. Heart, liver, and other organs, it should not produce hepatotoxicity or cardiotoxicity or nephrotoxicity. So, this is the properties of an ideal anesthetics. First, if you see the inhalation anesthetics, they are used primarily for the maintenance of anesthesia after administration of an IV agent. That means first intravenous anesthetic has to be given. That can be maintained by administration of the inhaled gases. The depth of anesthesia can be rapidly altered by changing the inhalation concentration. They produces very steep dose response curves. If a drug produces steep dose response curve, automatically it should have narrow therapeutic index. The safety of margin is very less if a drug produces a steep dose response curve. So it don't have any antagonist. Now, if you see examples of inhalation gases, best example is nitrous oxide, which is available in gas form. It's also have very good analgesic activity. Even at 20% produces analgesia, equivalent to that produced by the narcotic analgesics, morphine. It can be used as a carrier and adjuvant to other anesthetics also, and mainly it is employed for dental practices and also the OG purposes. Another volatile liquid which is used in gaseous form is diethyl ether, which are potent anesthetics. It also produces analgesic activity, and this is also produces muscle relaxation by reducing the acetylcholine output from the motor nerve endings. And if you see the halothane, it's a potent anesthetics. For induction, you will be using 2 to 4 percentage, and for maintenance, the concentration is reduced from 4 percentage to 1 percentage, and it has to be administered with the help of a special vaporizer. The major disadvantage is it is not an good analgesics or muscle relaxant. So if you see, go for intravenous anesthetics, on IV injection, they produces loss of consciousness. Whenever you are using intravenous anesthetics, that anesthesia has to be maintained by administration of inhalation, and it has to be supplemented with analgesics and muscle relaxant, and that comes under pre-anesthetic medication. For IV, we are using ultra short acting barbiturates called thiopentone sodium. It is injected intravenously at the dose of 3 to 5 milligram per kilogram as 2.5% solution. So usually it's I said it is the onset of action is very quick because it is given by intravenous route. So within 15 to 20 seconds, there will be a loss of consciousness. And thiopentone sodium can also be used for the treatment of or to control the convulsions. The propofol is supersedes the thiopentone as an intravenous anesthetics. It is an oily liquid employed as 1% emulsion. So this unconsciousness usually occurs after 15 to 45 seconds, and the duration is 5 to 10 minutes, lasts for 5 to 10 minutes in sub-anesthetic doses. So usually it is a drug choice for sedating intubated patients in intensive care unit. The next general anesthetics is etomidate. It is another induction anesthetics, but the duration of action is very short, 4 to 8 minutes. And this drawback of etomidate is it produces cardiovascular and respiratory depression and also motor restlessness. It is a poor analgesic, so it has to be supplemented with opioid analgesics. So I would like to give a brief introduction about the pre-anesthetic medication. Pre-anesthetic medication refers to the use of drugs just before anesthesia to make it more pleasant and very safe. The aim of pre-anesthetic medication is the relief of anxiety and apprehension. Usually, just prior to operations, the patients develop anxiety or a feeling of apprehension. Because of the anxiety, there may be increased sympathetic activity that may interfere with our operational procedure. So, the anxiety has to be treated by administration of certain anti-anxiety drugs and amnesia for pre and post operative events, and supplement analgesic action of anesthetics and potentiate them so that less anesthetics can be utilized. The example for pre-anesthetic medicaments are benzodiazepines like diazepam, lorazepam, can be given by oral route or by injection. The second one is opioids, narcotic analgesics like morphine, dose of 10 milligram, or tetherine in a dose of 50 to 100 milligram, can be given by IM as a pain reliever. It also reduces the dose of anesthetics required and supplement the poor analgesics anesthetics like thiopentone and halothane. The third group of drugs are anticholinergic because in case of cholinergic stimulation, there will be increased secretions and also laryngospasm. So that can be treated by administration of certain anticholinergic. In case of patients undergoing prolonged operations or cesarean section, and obese patients are have more susceptible for gastric resurgitation and aspiration pneumonia. So this gastric resurgitation or aspiration pneumonia can be treated with the help of H2 receptor blockers like ranitidine and famotidine. Certain general anesthetics may have a capacity to produce emesis, so that can be prevented by administration of metoclopramide 10 to 20 milligram intramuscularly preoperatively is effective in reducing the post-operative vomiting. So with this, I am concluding my lecture on general anesthetics. We will meet you again in some other chapters. Thank you.